So welcome to today. Today we're going to be talking about the secret life of the cornea. And my name's Scott Brown. I'm an optometrist. I'm based in practice in Edinburgh, and an independent practice. It's in the city centre, but we tend to get a kind of not a high street clientele. We tend to get lots of kind of older patients, lots of kids. In that practice, we've been doing myopia control and ortho-K and irregular cornea lenses I've been doing it for about 20 years. And we've been getting the NHS contact lens patients referred to me. So that's where my background is from the point of view of talking about the cases we're going to look at today. And I also do professional services for Scotland. So if you're interested in fitting lenses, it would be me that gets you set up and handles the inquiries for fitting more specialist lenses other than I perceive to be with the gas prims. Kind of more along from that, what I would say is I've got kind of two missions, and I'm going to make quite clear as to what my missions are during the talk. One is I love contact lenses. I think they're fantastic. I think they give patients a completely freedom from life that they wouldn't otherwise get. And I want you to kind of share in that passion. And the other thing is I really want to combat keratoconus and the impact that keratoconus has on practices. And effectively, I want you to just kind of join me at the end of this when you understand what's going on. Join me in that journey of trying to combat this, because we could actually get rid of keratoconus within effectively one generation if we do things. So we're going to discuss some points. What we're going to look at is the overview of the cornea to start with, looking a bit about the pathology, how we measure it in practice, and how it changes during life, because that's the kind of thing that I think a lot of practitioners are not au fait with, is how the cornea changes. We're then going to have two discussions that are dropped into this. One of them is on myopia control, and the other one is on corneal ectasia, or keratoconus is the other term for that. And these are the points that we're going to cover. So let's talk about the baseline cornea, so the measurement. Now this chart that I would use, this would historically have been used when we saw pediatric cataract patients that came in, so young kids that were going to need an aphakic correction. And this is the kind of the size of the corneas that we looked at. And what you'll notice is that very young kids have got small corneas, but by the time you get to about 2 years of age, the cornea is an adult curvature. Now we're used to dealing, in the UK, we're used to dealing with the cornea in millimeters, and you can see that we've got 775 to 795 by the time that kids get to 2 years of age. 780 is the average keratometry reading for patients. So at this point we've got 2-year-olds with normal sized corneas, but that doesn't necessarily mean that they're going to stay normal. They might change as time goes by. If we look at the next age group along, what we can see in the 6 to 16 group is that the curvatures don't change. So we've got the keratometry, and the group that changes the most in this group is actually the emmetropes, and they get a 0.05 millimeter change during that 10-year period. So why is this useful? It's really useful from the point of view of knowing that we've got this metric that we can start to measure with kids that is their baseline measurement. It's not going to change during their life. And then the next age group again, we then follow, and we can follow these much easier in practice. We've got a cornea top left-hand corner, so a topography map of a patient done in 2007, same patient done in 2021. The right-hand map is a subtractive map. The scale's scaled right down, so we would see any change there. You can see the green picture means there's no change in that cornea. So effectively, the information we take from this is that from the age of about 3, children's corneas are their adult prescription, or their adult curvatures. Now, at the age of 3 and onwards, we're then doing kind of fairly routine sight tests for kids, whether they're just coming in for screening or whether we're monitoring them. So 3 years is a kind of good age to start monitoring this stuff. And we are often now starting to fit contact lenses at a younger age. quite often from 6 or 7. So having the information about the cornea before we start is useful. But do we measure Ks on kids? So that's the question for us to think about over the next few while. And how important is the cornea in the visual system? Well, the cornea is the most powerful lens in the eye, at around about 40, 45 diopters, which is about the equivalent of a loupe magnifying glass. And that's why we see tiny changes with the corneal curvature causing really big prescription changes, as we'll talk about later on with ectasia. But of course, the other thing that we're understanding now is the cornea in relation to axial length. And if we look at this plot, you can see that if we've got a flat cornea, that's of course going to project the rays of light and focus the rays of light further away. So you're going to have a longer eye. And if we've got a steep cornea, we're going to naturally have a shorter eye if the patient is emmetropic. So the corneal curvatures are important when it comes to us understanding this in relation to myopia management, which is all to do with the axial length growth. Now, if we deal with myopic eyes, the myopic eye, of course, gets longer and it changes shape as well. So the way I describe it to patients is if you've got a myopic eye, you've got a kind of rounder eye, a bit like the base end of an egg. If you've got an emmetropic eye, you've got a rounder eye like the base end of an egg. If you've got a myopic eye, it becomes longer and it becomes more prolate, like the pointy end of an egg. But when you actually see a myopic eye and the scan of a myopic eye, you can see why these patients are at higher risk of getting retinal detachments and all the pathology that goes associated with myopia, because you can see how distended the eye can be as a result of the myopia. And of course, axial length is the big focus that we're hearing about now in relation to myopia management. The reality, of course, is that axial length doesn't really have an impact on the young patient. It has an impact on the patient when they get to over 40, over 50 years of age. And you can see the risk factors associated with longer eyes really exponentially go up. So we need to manage the message that we give patients where we're talking about managing axial length to the teenager, but actually the risk factor they're going to have is when they're older. And that can be difficult to manage. What we're really interested in is what happens at this side, to the left of the graph, when the patients are under 40. So let's have a look. If we've got corneal curvatures, now we're used to dealing with patients in this, again, this kind of fairly abstract millimeter curvature. So we can have a cornea that's 710 or 775 or 825, and you can see that the difference between those is 6.5 diopters. So if we don't measure the cornea and put it into context of what the patient we're dealing with is, you could have an emmetropic patient, and that patient could be 6.5 diopters equivalent being a myope because of the curvature of the cornea. And of course, we're starting to understand more about axial length. If we have axial length of over 29 millimeters, we're into this high risk category for patients. So for non-myopic eyes, the axial length stabilizes by about the age of 12, and then beyond that, about 50% of myopes will continue to increase with axial length. But having a note of this cornea can give us a useful estimation if we haven't got axial length in practice. And this is from the Primo study, the Catherine Saunders study, where you can see that you can estimate axial length from the corneal curvature and the prescription that you've got. So quite a useful study to go and have a look at for in practice if you haven't got axial length. Now, if we think about how we measure the cornea, on the left, we've got a keratometry Myers in the central of the cornea. On the right, we've probably got the gold standard, which is a topography plan on the right-hand side. What are we actually measuring when we measure the cornea? Well, the tear film thickness is fairly uniform across the whole cornea, 3 microns thick. The epithelial thickness is fairly uniform, about 50 microns thick. And then we've got the stromal thickness. So what we're really measuring when we look at keratometry is the stroma, the shape and the curvature of the stroma, because we've got this 2 equal thickness layers on top. I'm just going to run you through some of the information that we get if you're not familiar with topographers. So we get the metric that we're used to, or we're looking at corneas for normally, is the Ks. So we've got top right-hand side, we've got the Ks. We've got it there both displayed in millimeters and also in power, in diopters. They're exactly the same. It's just a conversion chart. Below that, we've also got the HVID, and then we've also got spherical aberration, which we'll talk about later on. And an interesting one is you click right on the middle of the cornea, you can see we get the power of the cornea. So this cornea is a 44.25 diopter cornea. And that relates to the colors that are on the map. You can see that the colors are kind of fairly average in the color scale at the top. A very steep cornea would have very central red colors. A very flat cornea would have very central blue colors. So this cornea is an average cornea. But also with this scale, we're wasting a lot of the scale. We're not using the blue and the red at the bottom. So we can crop the scale to zoom it into, we know we're dealing with a normal cornea, let's crop the scale. We can then see corneas in a scale that tailors it for them. So now all corneas will go from red to blue. Red does not mean bad. Red is just the steepest corneal curvature. And you can see the cornea on the left, we have a spherical cornea. So the vertical cross-section, 3D shape of that is very similar to the horizontal, versus the toric cornea on the right-hand side, where you can see that we've got a very flat cornea on the bottom through the horizontal and a very steep across the vertical. So where do we go with this? So where's this useful? Well, let's have a look at this. So here we've got a baseline cornea, and then we've put a soft contact lens onto that cornea. And you can see the bottom power change that's happened. Now this patient has got a -3 soft lens. Their cornea before we started was 44.5 diopters, or 44.4. And after, it's 41.4, which is pretty much, I'm not very good at mental maths, but pretty much 3 diopters less. So again, with the comparison map, let's let the topography do the hard work for us. We click on the middle, you can see we've got a -2.95 measurement of power difference in the cornea before and after. So if we put different powered lenses on the same eye, we can again measure that power difference, -2, -3, -4, to get that result. And this is us looking over a multifocal lens for myopia control. So we're seeing the power curves and the power change. That means we've got a different power rings. And again, with this one, it's a -250. We've got -2.38 on the visual axis. This kind of comes into play when we think about doing night lenses, ortho-K. Because the purpose of the night lens is to change the shape of the cornea. So we measure that corneal shape change by flattening off, by building up the mid-peripheral cells, giving us a flatter central cornea. We can only change the cell height by about 20 microns, so not enough for us to really see with fluorescein or slit lamp. But we use the topographer, and you can see the histological slides there. And that gives us a power difference. So a bit like the multifocal soft lens, you can see that we've got a treatment zone on the right where we've got the correction, and with this patient we've got a -2.64 diopter power change in the middle of the cornea. So it's fairly simple with topography. We think about the cornea rather than the lens. We change the cornea and measure the corneal power to give us the power difference that we need, whether it's -2, -3, or 4. So where is this useful? Well, we're going to have a look at a case history where this is a patient who was fitted in 2011, age 8, and at the time was about a -250 myope. Both parents were high myopes, but -10s. The mum went to a different practice and wore soft contact lenses, and her son had gone to the practice and just couldn't handle getting the soft lenses in or out. They were just too big and cumbersome. The dad was a GP wearer with me and asked, can we go for a GP lens? Would this lens that I wear be suitable? Oh, he's not a -10 yet. I said, well, yes, but actually there's another mode of wear called night lenses ortho-K that you can have. And the handling with those should be easier. and they might even get the benefit of slowing down the myopia progression. So that was what we did. So we went with the night lenses. Him and then his younger brother ended up getting on fine with the lenses. You can see that in the May of 2012, we're getting a minus 2.5 correcting his vision. Now that was back in 2011. The other thing that we've got, you'll see this figure here. So this is the spherical aberration. So this is what we're starting to understand a little bit now with myopia control. So there's other things that are changing with the cornea. So this spherical aberration is a number that we can measure to see how effective the myopia control treatment that we've got is. And we're looking for an increase in spherical aberration that can be measured with the topographer of more than 0.8. So you can see we're getting a good increase in spherical aberration as a result of that. And if we work out where he might have been, so this is plugging his statistics into the Brian Holden Vision Institute calculator. I don't know if you've seen that, it's worthwhile looking at. You can see that we've got an estimated progression of myopia where he would become a minus 4.8 myope over time. Now, when he's wearing night lenses, he doesn't want to stop wearing them because he sees he has naturally good vision, doesn't appreciate having disability of being myopic, wants to keep wearing them. So we don't want to take him out the lenses to measure his baseline prescription. The patient doesn't want to do that. So how do we know where he's at? So this is back in 2011. If we then look at figures from 2020, so he's now 17. He's never stopped wearing the lenses. And again, clicking on the power map, we can see that he's a minus 4.38 myope. So we've had to tweak the lens over the years just to top up the myopia that's crept in. But he's a minus 4.38. And 2023 information, we've got, he's a minus 4.03. So there's a little bit of, he was slightly overcorrected in 2020, we've reduced that. So effectively he's a minus 4 myope. Gone in age 8 at minus 250. And this is a way of us knowing roughly what his spectacle prescription would be if he was to stop wearing lenses. Good, so let's have a little bit of a discussion at this stage. We're going to go on and discuss another thing to do with curvatures. So effectively what we've done so far is the cornea is stabilized by about the age of 3, and we're measuring the stroma, the structural layer of the cornea for shape and power. And the topographer can give us soft contact lens position on the eye, it can give us lens position, spherical aberration, and a comparison map. Let's do the map difference. So the points for discussion are, what do we currently do in practice to measure the cornea? Now this could be any measurement at all that you can think of. And so far, would you make any changes on the record cards that you've got based on the information that you've seen with kids so far? So let's have about 5 minutes, have a quick discussion just in little groups, and then I'll come back to the room and you can shout out the answers and we can discuss them as a group. I can just call, I'm going to either pick on you or volunteer some information. So for the first question, what do we currently do in practice that we can do to use to measure the cornea? So what, shout out, volunteer an answer, first of all. Topographer, okay, good. Topographer is the gold standard. Hands up who doesn't have access to a topographer. Yep, the majority of the room, yep, okay. What next would we have? Keratometer. Hands up who doesn't have access to a keratometer. Okay. Okay, so you got the same things. And have you got access to a topographer? No keratometer, okay. Anything else that you can think of that we can use to measure the cornea? Yep, pachymeter is going to give us a measurement of the cornea. Yep, the OCT, so you've got the anterior segment and the OCT is another one. So let's think a little bit about the difference between keratometry and topography. So one of the main metrics we look at with topographer is the SIM-K. And I'm going to describe these as being touchy-feely. So there's a degree of touchy-feeliness with the keratometry. You know, if you're measuring Ks with a patient, you might think, oh, well, the Ks are they're breaking up. They've got a dry eye. I'm seeing a non-invasive tear breakup time. You might also be able to get the patient to look slightly differently to see, oh, there's a skew in the K readings when they look slightly off. So there's a degree of touchy-feeliness about that. The topographer, on the other hand, gives you this one image. Now, it's giving us one image that is also the touchy-feely bit. It's giving us the whole cornea in a power profile, and we can then compare that from one year to the next. And if you compare the Ks that you would get from a keratometer to the Ks that you would get from an autorefractor, you don't have the same touchy-feeliness with an autorefractor. Now, that works both ways. If you've got an autorefractor, you should be getting the same result every time. So you should be able to get a comparable result from one test to the other, but you lose that touchy-feeliness that you might have with it. Anything else that's going to show us the power of the cornea in a really touchy-feely way? RET, yeah. So a RET is going to give us some information about the cornea as well, and that's something else. It's really touchy-feely, both from a doing it perspective. Do you use spot? Do you use streak? And then the other side is how would you convey that on a clinical record? I did RET and I got this appearance, and then I communicate that to the next optometrist if it's going to be a different person. It's really difficult to do, but it's definitely there as a device that we can measure the cornea with. Right, so far, any changes that you would think, oh, I'm going to do a little change to my record keeping with practice now? Anything at all? No? Fair enough.
So far, so I got a top of my...
Good, okay. Yeah, so kind of all information is good information, and so you're thinking you've recently got a topographer, rather than just using it for the group of patients that you know it's suitable for, you might start to use it for other people. Okay, we'll come back to you later on. Yeah, so how reliable is an autorefractor for Ks was the statement. They should be fairly accurate, particularly in a regular eye. So it's a little bit like non-contact tonometry. It's really accurate when you've got an average thickness cornea. Get a really extreme thick or thin cornea and the device loses its accuracy. So they should be fairly accurate and fairly repeatable, but that's an advantage where the keratometer, you've got that, especially if you're seeing the same patient, you can kind of know you're doing it the same way. You can put question mark. There was something a wee bit weird this year about the Ks, whatever. Whereas with autorefractor, you've just got the reading that you go with. So you have to assume that they're accurate.
Because now a lot of places are doing pre-screening, and therefore you're just getting that result and then recording it, where a lot of us are probably just going, I grade Ks because it's not...
Exactly. Do we pay much? Well, that's it, and that's a good point, and that's something that hopefully by the end of the session today you leave with a little bit of a change in thought about, do we measure it, but do we actually pay attention to it? Because that's also two different things. So that good point to come on to. We're using the keratometry with the Primo study kind of thing to give an estimate of axial length. Yep, perfect. That's good. We'll come on to that a bit more as we move on. There's a discussion here. Can I just, I think it was this table, you were talking about myopia and the parents with myopic. Anything that, the sort of minus 250 in the topography, was there anything that you want me to elaborate on with that? No? No, that's fine.
Well, your guy, your young lad,
particularly
-4.
Yeah.
Many years, then you think, well, where's the myopia?
Well, so he was predicted to be a minus 4.8, and he's a minus 4. So that's 0.8 of a saving, effectively. Well, okay, this is where the data comes in. So if you saw a minus 250 patient who was 8 years old with both patients at minus 10, if we're going with the data, he was going to be a minus 4.8.
Are you saying he was predicted to be -4.8 with the treatment?
No, apparently he would be a minus 4.8 without. Yeah, yeah. So there's been 0.8, effectively there's been 0.8 of a prevention of myopia with that patient, which is still a 40% reduction in risk factors, near enough. But part of the issue that I have with this is that I know you've got to go with the data, but both patients, minus 10 and a 250 myop at minus 8, I would probably have expected him to be a bit more than a minus 4.8 by the time we finished it. Yeah. Well, that data is definitely right. That's when you plug it into the Brian Holden Institute. That's what you get with Caucasian and the prescription. So that was how it was when it was done. But I think that's probably a conservative way that I would look at it. From the kid's perspective and his brother, they've had an entire childhood of not wearing specs or day lenses. They don't perceive themselves to be myopic. They don't see themselves. So they've had a benefit during their life that's kind of almost better than the myopic control element of it. The corneal ectasia, often sometimes just called keratoconus, but it's kind of a bit of a difference in conditions. So if you look at the corneal cross sections we've got normal cornea on the left, where the topography maps are symmetrical, so the top and the bottom, the left look the same. We've got keratoconus, where you can see that there's thinning of principally the apical cornea starts to thin, versus pellucid marginal degeneration, where it's the kind of inferior cornea that thins, and then keratoglobus, which is where you've got the whole cornea, kind of just a more extreme version of keratoconus. So ophthalmology doesn't really differentiate particularly between these conditions because they're all kind of similar etiology, but from a point of view of us correcting patients with contact lenses, they have a bit of a difference. And principally, contact lenses is what's going to give the patients the good acuity, and the reason for that is just on the visual optics of it. So if we've got a regular cornea, it focuses the rays of light all to a point source of light. If you've got an irregular cornea, as the rays of light go through the cornea, they get scattered, and that causes a softer endpoint with prescription, usually higher sales and higher prescriptions. So when we put a contact lens on the eye, we trap a layer of tears, and it's that trapped tear layer that neutralizes the corneal power. So it doesn't really matter often whether it's a corneal lens or a scleral lens as shown here. It's the tear lens that's actually doing the magic and neutralizing the front surface corneal powers. There's obviously back surface cornea that can mean you still have a reduction. So this is us looking at a scleral lens. You can see we've got this big trapped tear lens in front of the cornea. That's what neutralizes the corneal power. The lens only fits on the sclera on the left, so all of the bearing of the lens is on the left-hand side. And if we look at a trapped tear layer with a scleral lens, so the scleral lenses are all made to be a certain thickness. So you're going to use that thickness when you look at the patient, because that's reliable. So we've got this 300 micron thick contact lens. We want to have around about a 300 micron thickness tear lens with a scleral lens. So we use the lens as the metric, and you can see that the tear thickness is roughly the 300 microns. And then this is the cornea of this patient. And you can see that it's 216 microns thick. 260 microns sounds like quite a big number, but if you think about that in millimeters, it's 0.2 of a millimeter in thickness. So this is a cornea that's becoming quite thin. And if we look at a cornea, what happens next to these patients, so this is a cornea. Now this cornea is a bit fuzzy, but it's very thick. It's got lots of fluid in it. So this is what happens during eye drops. You can see the cornea, the photograph underneath. It's very cloudy. The cornea is swollen. The patient won't be able to see when this happens. It used to be that this was kind of rush them in and it was an emergency graft. Then it was, we'll just leave them because the cornea will scar. That scarring process will then give the cornea solidification and strength. And if the scar is not on the visual axis, the patient will be able to see again. If the scar was on the visual axis, then yes, they would probably need a graft to remove the scarring of the process. So this is kind of the worst case, or this is where keratoconus goes to in the worst case. I'm going to show you a video on cross-linking. If you're squeamish, you might want to half shut your eyes. So this is corneal cross-linking. So we've got a patient, and they're asked to look straight ahead, whilst the swab of isopropyl alcohol, which if you found in your garage would probably be brake cleaner, is soaked onto the cornea, and this is going to soften the epithelium. And what you hear, or what you can't hear, is the surgeon saying, yeah, keep looking straight ahead, don't move, keep looking straight ahead. So the isopropyl alcohol was put onto the cornea, it starts to soften the cornea. Now we think about, touching the cornea and all the rest of it, and the cornea's been super sensitive, so you're about to see how they then wipe off the cornea after it's been softened with isopropyl alcohol. So it's started off wiping like this, and then they just get stuck in. So this is how corneal surgeons treat the cornea, and this is part of the reason why you need to have a minimum corneal thickness, because the corneas need to be able to resist this. You then put riboflavin, a vitamin drop, onto the eye, and that's going to absorb the UV light. So you're then going to zap the eye with the UV light. UV light, as we know, causes skin damage and aging of the skin. It also, in a dose, is going to age the cornea. So we're going to age the cornea by 100 years, maybe. The UV light means that the cornea absorbs the UV lights. The UV doesn't go in and cause any changes with the lens. And then they're given a bandage lens, a pat on the head, some paracetamol. So patients have effectively the worst corneal erosion that they're ever going to have in their life, and also the worst dose of sunburn that they're ever going to have in their life. But it's very, very temporary. Lasts for a couple of days, normal painkillers, and then the cornea is usually a bit hazy. It clears up over a couple of weeks. The success with it and the outcomes with it are fantastic. Now, this is a relatively new procedure, which is why I really want to highlight the impact of how this procedure that's in ophthalmology can affect us as optometrists. So it's new. It's a preventative treatment. And if we think about preventative treatments, well, at the moment it's all fantastic about we can prevent myopia. So that 0.8 diopters that we may have prevented with the patient Mark is all about prevention. So myopia develops in childhood. It can cause a risk to severe vision loss. It's very, very prevalent, which is why it's affecting so many patients. And if we change things, we can then potentially reduce that patient's risk. Now, we also deal with other preventable conditions. One we're very familiar with is glaucoma. So again, it develops generally in the over 40s. It can result in severe vision loss. Now, if we were to think about prevalence, so the prevalence of glaucoma in patients under 64 years of age. So hands up who would do fields and pressures or glaucoma screening on patients under 64. Everyone. The flip side of that question, would it therefore be neglectful to not do fields and pressures on patients under the age of 64? Hands up if you think yes. Again, all the hands, I think. Yeah, good. So, and we detect glaucoma with instruments to pick it up early before it has changes, and then we can reduce the impact. If we look at keratoconus, so it develops in childhood, usually in the teens. It also results in severe vision loss. It also has a prevalence of 1.4%. And again, we use instrumentation to pick it up. And now, this new corneal cross-linking effectively is a preventative treatment for keratoconus. So patients now all have access, in all of Scotland, they have access to cross-linking on the NHS to have it prevented. So I'm going to look at another case study with you. Different child. So this patient came in age 11. Plano prescription, acuity 6.6 minus, that goes right through. You can see that till they get to about the age of 17, where they're, you're myopic. I've got some fancy specs that I can sell you. So you might prescribe myopia, you might prescribe glasses for it, and then the patient comes back in for their checkup about a year later, and you can see, the prescription's gone all wonky. It wasn't myopia. So if we're just relying on prescription and acuity, we could miss something. If I show you the topography that goes with this patient, you can see that we would be picking up keratoconus at 2008. suspicious slightly in 2006, but not really anything to note of. But there's definitely a change between 2006 and 2008. Now, I've shown you two different plots here, not to try and confuse you. The top one is tangential, which is the one that shows up small changes in the cornea. The bottom one is axial. So axial is the power plots, more akin to what we're going to see with RET. If we look at the bottom plots and we put a kind of 5 mil pupil onto the plots to simulate a 5 mil pupil with RET, and we also look at the Ks, the keratometry readings that we might rely on if we don't have a topographer, you can see that the Ks don't really change until we get to age 17, where we get a 0.4 difference in Ks, whereas the year before, it's only 0.1. So there's not a good correlation with Ks. And again, with the kind of how this might show up on RET. On RET, we're looking for a difference in the pupil. So we're not going to see really anything on RET until you get to the same point where you've got the green covering most of the pupil, and then this orange part is going to throw in the scissor RET reflex. So this is a way of us representing what we see. So RET and keratometry could still be missing out on this early keratoconus diagnosis. And of course, we can do a subtractive map. So the subtractive map in this patient between 2006 and 2008 shows that they had a 2 diopter power change on the corneal apex. So clear as day that they're developing keratoconus, even although the prescription is still a plano prescription with good acuities. So corneas are adult-like from around about the age of 3. We can start to monitor and screen it. It's valuable to screen for preventable eye diseases, whether it's myopia, glaucoma, and now keratoconus. Keratometry and understanding of the cornea is beneficial from the point of view of both myopia control, but particularly from ectasia. And topography can pick up ectasia at least 6 years before we would see it with traditional methods, even if we're paying attention to those methods. And this is where I want you to join me in this journey is, can we do something now from a point of view of optometrists? Could we prevent, in Scotland, almost every patient becoming keratoconic? Could we pick it up early enough that they got cross-linking done? So early detection means that young patients are going to have a much, much better outcome. So, discussion 2. So now, what changes would you intend to make in your practice, even from next week, on your patients that are under 40, based on the information that you've now got? And then what changes would you like to see in your practice or in optometry over the next 5 years? So think about this as a 5-year goal for us to do something about it. So discuss these 2 points in your groups. In the room, I'm just going to show you one other thing. So I should have put this up as a bit of a thinking for you during the discussion, but there you go. That was the case example of the ectasia. I'm going to show you this video. So this is a video. There's a really good YouTube link here, and if you just go into YouTube and just type in MRI eye rubbing. So this is an MRI scan of what happens when a patient rubs their eye. So if you haven't seen this, it's really quite amazing. Is it started? There we go. Now this is not kind of some mad eye rubbing. This is just normal eye rubbing. It's not entirely agreed with, but in there's still debate as to what causes keratoconus. So eye rubbing is certainly thought to be a contributing factor as to why patients are one eye or other. And if you go and watch the YouTube video, these ophthalmologists are quite convinced that eye rubbing is quite a key thing. Interestingly enough, I got a really bad bacterial conjunctivitis when I was 17 in my left eye. And I definitely rubbed my eye for about a day and a half. And I have asymmetrical astigmatism in this eye, about 1.5 drops of silt. So and before that, my memory, and of course patients always have this memory, oh, my vision was perfect when I was younger. So, but it hasn't changed since as an adult. but it would kind of, I could kind of see that there's a degree of this that is actually causative. Now that might be due to hay fever, allergies, the eye rubbing is something that we need to, but also us just knowing to tell patients and tell parents, does he rub his eyes a lot, you know? Don't tell him not to rub his eyes. Make sure you get an antihistamine, try and manage the eye rubbing because it could be causative. Good, so from the discussion points, let's go back. Where did we, what points did we raise? So would you change anything that you would want to go into practice next week and do? Hands up if you've got something in the group where somebody said, yeah, I'm going to do something a bit different. I'm going to suggest that the people with the topographer are probably going to do the topography on more patients. Is that right? Yeah.
Program. Similar to diabetics, I think, where every visit they have a topography on children.
Yeah.
That's the way forward, like.
Yeah. So look at implementing a routine topography for children practice. So that's what I do. The topographer that I've got gives you quite a colourful photograph of the eye. So it's actually kind of almost saving me a little bit of time during the examination. If I just do the topography with the patient, I'm getting a colourful image of the anterior eye along with the topography. So I want to get all kids, whether they're emmetropic or not, a baseline scan. So the baseline scan will then be the one that I'm going to refer back to in 5 or 10 or whatever years time. Because again, that baseline information we know is good from the age of 3. So as soon as the kid's old enough to get at the topographer and not fidget, in order for you to get a result, you've then got data. And on that touchy-feely side of it, the topographer is quite good because you're getting that whole corneal image shape that's not relying on something like keratometry. What if you haven't got a topographer in practice? Sorry, there you go. So that was another question that came up earlier. When is corneal cross-linking suitable? So there's no minimum age limit with corneal cross-linking. So the hospitals want to see patients as soon as they can. The earlier, the better. Most of the hospitals will need to do a baseline scan themselves, and they do that with the pentacam topographer, which is going to show them both front and back surface cornea, because you can get keratoconus where the back surface of the cornea changes, but the front surface, which is what most of the topographers that we're going to have for contact lens fitting, doesn't change. But they'll get both information. So they want to do a pentacam scan at baseline, and then they'll want to repeat that 6 months later. And whenever they detect any change, or there's criteria, 0.75 refractive power change, or any change in thickness, then that's when the patient will be eligible for cross-linking. And there's no minimum age. So there's kids that are 7, 8 years old that have had cross-linking done. I don't know how they did it. Yeah, I would presume with a kid they would knock them out. Yeah. So luckily there's not a huge percentage of patients. So the 1.4%, they're going to come in gradually, over the point that we're screening them. And I think the corneal clinics would probably prioritize those because they know that if they do the cross-linking, the knock-on effect is they're not going to have to do the complex management, the grafts that come down the line. So certainly I can only really talk about in Edinburgh, where there's the care and the cross-linking that's available is excellent, effectively. There's not really any waiting list. It's never perfect, but there's no waiting list. I don't know about different areas around. But from speaking to the corneal consultants in Edinburgh, the whole of Scotland has effectively got the same access that they have.
What's your views on charging?
So what are my views on charging for it? Well, ideally, I'd want to see NHS funding for this, whether it's instrumentation put into practices but the reality is, are we going to see that? I don't think we are. I, as a parent, and I know from the other parents that I've got, would be quite happy to a lot of the parents to pay a little bit to have something done. And I think that you've just got to, as a profession, we've just got to work out, okay, there's new technology coming through. can I afford to subsidise it in my practice? In which case I'm going to do it. Or if I can't afford to subsidise it, I do want to offer it to patients, and I'm going to offer it to them at a charge that's going to be appropriate. And I think if we wait for the NHS to respond for this, it's going to be too late. And the other thing is that there is litigious cases going through where optometrists have been pulled up effectively for not missing keratoconus and referring keratoconus. And I would say that a lot of the patients that make it to me, by the time they've come through the optometrist referred them to the NHS to me, a lot of patients for keratoconus are quite far gone. It could have been picked up way, way, way earlier. So there's certainly an advantage from the point of view of charging for it. I think if you're going to charge for it, charge for it. But we shouldn't necessarily rely on the NHS, both from a funding perspective, also from the NHS to protect us as practitioners. Any other points? Yeah. So that was a show of hands for who's got topographers. So, and it's quite probably a higher percentage than average. There's probably around about 20% of the room here have got topographers. I think on average that's probably 10% practices. I think if you've got a change in case and that's where you can do something about it, even if you've got limited, your hands are limited to tied. Yeah. For referrals, I think having a number is probably better and better appreciated. So if you were to refer saying my Ks have gone from this to this to this, and maybe the vision is not quite good, or there's a bit of a question mark for Ks, because you can imagine how much of a black art retinoscopy is for ophthalmologists, then they're more likely. And I don't think you would get much kickback if you've got something that you're saying, for the instruments that I've got, I'm showing that there's a change. I think they would be quite welcome to see that, because they know that topography is what they need to do. If you've got topography, then it's as clear as day and you're referring with good justification, but I don't think the corneal clinics would be concerned with that.
Just to take on from that point, it's a very unfortunate world we live in.
That's right. And now, one of the things, other lectures that I've done on topography, about 30% of patients will have a skewed corneal apex, and they're just normal patients. So you wouldn't really pick them up so much on Ks, but it's the topography. If there was something weird with the topography, and I've seen topographies that are really strange, where they've come back and the ophthalmologist is happy that it's not keratoconus and it never progresses with time. So you do come across these odd patients, but they're going to be the 0.00% of the patients, which is not going to clog up the referral process.
Can I ask how long you take for a routine eye examination?
So the topographer that I've got, which gives you this kind of image. So I've got time in a 20-minute under 16 eye exam to do this, because it's giving me the baseline anterior eye stuff as well, effectively on that image. So it's literally quicker than doing a photograph or quicker than doing a slit lamp assessment. So you can build that into the routine, or I can build it into the routine of a 20-minute under 16. I don't sell the topographers, by the way. If you want to get a topographer, speak to Bib. They're not, they might be here, I haven't seen them, but Bib do the Medment. There's Topcon have got a topographer as well. Effectively, all topographers are going to give you this information. Yes. Yeah, and I'm not charging for it, but there's no reason that you couldn't build it into an enhanced eye exam or a care plan where there was a fee for it. And I don't think we should be scared of that as a profession, because this is one disease process in optometry. So as things go forward and technology gets better and better, and you've got tear film, and you've got red light therapy, and you've got dry eye treatments, and you've got IR stuff. I mean, all of this stuff we can't expect for the NHS to deal with it for us. Anything else come up? Good. I think it's coffee time or lunch time, so I'll let you. Thank you.